Welcome, everyone, and thank you for joining us for this installment of the Rock Health Summit virtual series. Primary care stands at a pivotal moment, simultaneously under immense strain and poised for transformation. Amid workforce shortages, rising patient complexity, and chronic underinvestment, AI and digital tools have emerged as potential lifelines in primary care. But whether these technologies strengthen or erode the core values of primary care will depend on how they're developed and implemented. In this conversation, we will dive into what it takes to ensure technology is shaped by the people it aims to serve, supports the full care team, and ultimately restores purpose, trust, and equity to the front lines of healthcare. I'm thrilled to be joined by a group of leaders who are not only grappling with these challenges, but actively shaping the solutions at their organizations. So without further ado, I'd love to have our panelists introduce themselves, maybe starting off with Dr. Jen Peña.
Thank you, Chris. It's an honor to be here. My name is Dr. Jen Peña, and I'm an internal medicine physician by background, and I am in San Juan, Puerto Rico. I spent the majority of my career in the U.S. military, and for the last 6.5 years, have been in digital health and in primary care. Here at home, I work as a chief medical officer for a company called Wisp, which is a female telehealth platform, mainland US based. I also consult medical direct and PC owned for several telehealth and digital health organizations. And I run my own direct primary care practice here in Puerto Rico.
Thanks, Dr. Peña. Maybe we'll turn it over to you, Dr. Rich Milani.
It's great to be with you all. My name is Richard Milani. I am the Chief Clinical Innovation Officer at Sutter Health, which is a Northern California-based health system. My background, I trained in internal medicine, preventive medicine, and cardiology. I spent a large part of my career at Ochsner Health Center in New Orleans and the last several years now at Sutter. I've been in the digital health space really since about 2014. It's great to be with you all.
Hi, everyone. I'm Dr. Nipa Shah. I am the chair of the Department of Community Health and Family Medicine at the University of Florida in Jacksonville, where I've been for about 15 years. But for the last 6 years, I've developed an interest and a passion for artificial intelligence and how it's going to change our field. I try to teach about it to a variety of different audiences. I have some training at MIT in AI, and I just am very passionate about this subject and happy to be here.
Thanks, Nipa. As you all know better than anyone, primary care is under immense strain. Shrinking margins, burnout, workforce shortages, to name a few of the major forces. How do you see digital tools and AI helping to address these structural challenges without adding more burden?
I can tell you, based on the work that I'm doing, and I understand Dr. Shah is doing something quite similar, we've been working with digital tools to free up primary care from managing chronic disease, many chronic disease issues. So let's just start off with the problem. I mean, let's get past the primary care problem. The problem is that the health system basically across the globe does a pretty poor job in managing chronic diseases. Our current control rate for hypertension nationally is 23%. We have failing control rates in diabetes and COPD. I can go on. And there's a lot of reasons for this. Clearly, primary care is overburdened, but there are other reasons too that are sort of baked into the type of systems that we have. There are other ways that we can utilize digital tools that can supplement primary care in terms of managing these kind of problems. We published our findings back in 2015 and 2017 looking at hypertension, diabetes, where again, we took it's almost like a Coumadin clinic model where we took the load off of primary care, have a focused factory where we're collecting data directly from home and actually managing all the medications. We're actually using guideline-based therapy and actively managing the patient's medications. And we're getting typically about 3-fold better control rates than standard of care, high levels of patient satisfaction, net promoter scores in the upper 80s to low 90s. And as a result of better control, we're seeing reductions in hospitalizations and the outcomes that you'd expect from better control for managing these conditions. So, primary care is an overburdened workforce, and adding more work to them is not going to solve the problem, but changing how care can be delivered can certainly alleviate some of the problem and allowing primary care to do only what primary care can do. And so I think a lot of the day-to-day management of these kind of conditions could be handled through other mechanisms. So that would be an example, for instance, of utilizing digital tools to be able to help reduce the burden currently exposed to primary care.
And Nipa, how do you see this reflected at your institution? I know obviously at an academic medical center, you're thinking about this pretty intensely as well. Anything beyond chronic care really come to mind where you really see these tools having an ability to really kind of address and shape structural challenges?
Absolutely. So one of the main benefits of AI is ambient listening tools to help with documentation. And we have to make sure, not just in academia but in private practice as well, that we have really good measures of return on investment, so that there is buy-in from the leadership that this is something that's worth investing in. So we did a before and after of 3 measures. Definitely increased productivity, which included increased billing and accuracy, patient satisfaction scores, the doctors looking at you and not at the computer, and also this the and pajama time, the time spent by the doctor after hours completing their notes. And in all 3 of those, we saw significant improvement. And the one that really resonates with a lot of people is the one that shows increased productivity, because you're billing a little bit more accurately and better, because you're not kind of lowering the billing code because you just don't have time to write everything down. So that has been very helpful with us. The other thing, because what distinguishes me is the academia, is medical education and primary care. So we are really revolutionizing and kind of going back to the drawing board of how we teach. Almost every medical student that comes has already been exposed to AI. So how do we make sure that they are engaged in learning primary care? And we also are up to date on how to use AI to assist them, to augment our learning, our teaching. So we have a lot of resources that we devote to training the trainer on AI, so that they can then use it effectively to educate the students.
Yeah, that's another great example. And I think there's still kind of this realm of structural challenges that we talk about in the world of primary care, whether that's kind of the shrinking margins or financial reimbursement for primary care, or thinking about really kind of how the system is best enabled to enable folks to access primary care. Thinking about either of access or sort of financial reimbursement and margins in primary care, or other structural issues, do you see digital tools and AI really helping there as well?
Well, I mean, I think the points that Nipa just brought up, I mean, obviously, improving coding is obviously a way to, improve reimbursement for the work that you actually are doing, but that you don't have the time or to be able to sort of document all those components. So yeah, I think that there can be other avenues of revenue through that. The other thing that is to be able to sort of using artificial intelligence to sort of triage risk among your patient population, and to be able to focus your attention on those that are at the highest risk. If you're taking risks, so for instance, you're in a Medicare Advantage type plan, obviously focusing more on those that are at high risk could result in greater revenue returns by virtue of reduction in hospitalizations and ED visits. So there's a lot of ways that AI could be pointed from a clinical perspective to really change the reimbursement model depending on how you're reimbursed, whether it's through value-based care or through a fee-for-service, mechanism.
To piggyback off that, when you think about return of investment, I think about it under the lens of quality and quality assurance. And AI really has a lot of tools. I'm personally working on a pilot right now where you can really deliver, a much higher, quality of care and, gain on your return of investment. You can catch those gaps in real time. You can do a lot better in terms of, adherence to guidelines. You can reduce a lot of variability between those providers and give more consistent care. So on the ROI side, if you're automating tasks like those audits and those reviews of documentation and compliance checks, that's really going to help you reduce a lot of those errors and liability risk and improve your reimbursement.
Yeah, I do want to mention about access. So probably the biggest barrier to having people have good health is access, no doubt about it. And there's so many layers to access when we talk about that. One of the layers, of course, is communication, and the inbox messages from our patients are overwhelming. So using AI to automate some of those responses so that the ones that you actually receive are the ones that are relevant is definitely a useful way to improve access. The other barrier to access is different ways in which people like to receive messages and communication. So I counted the other day, there are actually 18 ways that someone can get a hold of me. And, in the recent past, our institution would just literally call the patient if they missed an appointment. And if they didn't reach them, well, check box. We tried to reach them, we're done. And AI can be really strategically utilized to reach the patient via their preferred method without too much of a human input or human energy invested into how they want to be reached. And then the third part of access is language. People speak different languages, and even if you speak English, you have different levels at which you understand English. So using AI in our patient care handouts is something we do pretty uniformly in our department, and making sure that we are reaching the patient's level of understanding and also the language that they're most comfortable with.
Yeah, that's great. And I want to pull on that thread for a minute. I think you both raised really good points around really designing AI in ways that will improve issues of access in ways that hopefully help uplift communities that have historically lacked access to primary care or that have had challenges in accessing primary care. And so I'd really like to understand, how do you all think that we avoid repeating the digital divide in primary care transformation? What are the principles that must guide responsible deployment of AI, particularly when thinking about historically marginalized communities?
Take a stab at it, because for me, this isn't a theoretical question. It's very real. I'm living it right now here in Puerto Rico, practicing boots on ground, as we say in the good old army, right? And building those digital health solutions for patients across this island. It's very promising, but there's a lot of pitfalls and challenges. We have a lot of world-class talent in medicine. We have a lot of resilience, but we have a lot of barriers. We have a lot of broadband issues. We just experienced this past weekend, with a major hurricane not even crossing us, but passing up the north of us, and we still had issues with, broadband, power, limited resources, and it's communities like mine that tend to feel forgotten by the U.S. healthcare system. So digital health really, can provide a solution, but we need to remember we can't just pull it from Silicon Valley and drop it in places like Puerto Rico. These tools have to be adapted to the local context, the local reality, the language nuances. I'm actually working on a project with an AI bot that, was translated into Spanish, but it didn't have all the nuances of Puerto Rican Spanish, right? So we can't just pop it into ChatGPT, pun intended, and get a literal translation. We have to, be cognizant of that. We have to be cognizant of people's connectivity, and we really have to bring those clinicians to the design process, because it has been very clear that the technology has to match their reality, and when it doesn't, it becomes challenging. So, in my own practice, really, I've just been trying to focus on blending that in-person care too with those digital tools, because culturally that's a very important thing, that in-person care. But AI has extended my reach tremendously, and when you show patients this, when you can triage patients asynchronously, when you can prevent those care gaps and prevent issues down the line and really personalize the experience, then it becomes a tool that they can trust. And trust is really important, but it has to be built on cultural competency. And what I can say is, these tools really can help us close those gaps, but it has to be baked in from the start, equity that is, because you can't avoid that. If you forget about that and baking it from the beginning, then you're going to risk hard coding the same disparities that we have been fighting to get rid of for decades, right? So that's been my experience here back on the island.
Yeah, and tactically speaking, Rich and Nipa, as you think about your work at your health systems, how do you really ensure that you're closing that gap between sort of technology and reality, as Jen put it, and ensuring that equity is really embedded as a design principle from the start in the various AI initiatives that you're standing up?
Yeah, I mean, Jen brought up a lot of great points. I'll just add to that list, and that is, for instance, we've developed a lot of bots, some of which are avatars that can provide coaching or education, and moreover, not only languages can you alter, but we can do this at different literacy levels for individuals, and we've actually created that at very. In other words, we assess health literacy on the front end, and then the modality by which we educate you is based on that. So it's based on language and health literacy. And so really, I mean, so now we're able to reach people in ways that we couldn't reach them at a level of understanding on their side that is far different than what the typical after visit summary that you might get as you check out of a primary care's office or a specialist office for that matter. That's a creams handout, that's one size fits all. That doesn't really, that's difficult to read and may not work in your language or at your literacy level. So I think this is going to get highly personalized. I think it's going to be able to expand our reach in terms of impact. It's not just a matter of reach. It's, reaching with impact to the individuals that we need to reach. The critical thing that is, though, is also was brought up is, there has to be some sort of digital connection. So, if there's broadband issues, if there's issues, in terms of being able to access, even all you need is really cellular capability. But even, with that withstanding, that will be a problem. And that's something that I think is beyond health systems capability. We have to be able to acknowledge that. But if we're going to be successful digitally, we're going to have some kind of a ground infrastructure that anybody can access.
I'll tell you what we did at one of our clinics. It is 94% underserved, government funded insurance population. And we started simply. Every patient that came in, when it was time for them to review their labs, we asked them to pull out their phone and showed them how they can review their own labs. Like the medical assistant, that was part of their protocol. So it wasn't the doctor coming in and opening up the desktop screen and looking at the labs and talking to the patient. It was the patient themselves, and the MA would teach them that. And then when the patient went to check out, the follow-up appointment, we asked them to open up their portal through the electronic health record and make their own follow-up appointment. So I think the key word here is what Dr. Peña said is trust. They have to trust the technology. There's a lot of distrust, even when we get consent for, hey, is it okay if we record this conversation? You can tell there's a little bit of hesitancy. So, but once they start using it for the simple low-hanging fruit, like making follow-up appointments themselves or checking their own labs, and they get very comfortable with that. And it only takes maybe once or two, at most 3 times, that you have to teach them how to do it. And then they're pretty savvy about it. But that became our culture at the clinic. We actually made that part of our medical assistant protocol that, nobody, if they're here for lab follow-up, or if they had labs done, they actually have to pull it out themselves.
Yeah, that's a great initiative. And I know we've touched on this a little bit, the idea of ROI of AI, and I'd love to dig in a little bit more on that topic. Specifically, a lot of organizations talk about the ROI of AI in terms of physician time saved and other efficiency gains that will enable providers to work at quote unquote top of license. And that's certainly one way to think about value. And Nipa, I know you mentioned in addition to that, some other ways that the University of Florida is thinking about it is patient satisfaction and pajama time, which I think are great additional metrics to be looking at. I'd love to kind of ask you all what you think is really an appropriate frame for thinking about ROI in a primary care setting, really outside of efficiency metrics. And maybe Jen and Rich, we'll start with you.
Yeah, so when we talk about top license and being able to get the most out of your clinical care teams, I think a lot about these tools on reducing that cognitive load. Making sure that these tools are able to surface guideline-based recommendations. Say, for example, if you're using an RN-based triaging group, can you provide these guidelines to them in a way that can help them flag cases at risk, that can help them flag care gaps and give them real-time alerts so that they can action on them quickly. And for physicians and your prescribing providers, then that allows them to focus on more of the nuanced judgment rather than on the rote checks that we have to do that consume so much of our time. So I think, I think about it again on how can we use it to reduce that cognitive burden and load.
Well, I'll start off by challenging you and saying, what ROI are we talking about? A global ROI or a financial ROI? So if we're talking to our CFO, all he or she's going to care about is, this cost me this much. Am I getting at least that much back in dollars? And so if we're looking at a pure financial ROI, which is far different, because I agree. I mean, pajama time, all those things are great, but unless I'm seeing more patients, the CFO doesn't care, right? And so there becomes an issue in terms of ROI. And also, if you're talking about financial ROI, it depends, are you in a fee-for-service model or in a value-based model? Because I can tell you in a value-based model, it's very easy to construct a financial ROI for many of the capabilities that AI is providing. So back to Jen's point, I mean, clinical decision support. There's just a lot that, in 2020, the Institute of Medicine, the National Academy of Sciences came out with a report about AI in healthcare. And the conclusion of that report, there were many conclusions, but one of which is we've crossed the line in terms of our ability as humans to make decisions when you get past 2 to 3 variables with 2 outcomes. And now we're in a world of proteomics and genomics and many other sort of variables that come into the equation that is beyond human capacity to decide. So the only way we can advance ourselves is through additional intelligence sources like artificial intelligence to be able to make the best decision personalized for that individual going forward. So we've crossed this barrier, according to the National Academy of Sciences, in 2020. And it's only going to get progressively more of a problem. So to make the best decision for that individual, even going beyond that, there are capabilities, obviously, in decision support that would be very beneficial to give the best outcomes for that individual. And obviously the best outcomes would mean less hospitalizations and less ED visits and less, et cetera, et cetera, et cetera, which is good for the person and it's good for the payer of the healthcare. And of course, if you're taking risks, then that's a financial ROI. So the financial ROI comes in various forms. And like I said, part of that is determined by the systems that you operate. But I can tell you that we've crossed the line 2 years ago that now the majority of people in Medicare are now in Medicare Advantage programs. And so that means that, again, more and more of what we do going forward will be in a value-based sort of arena.
Do you see the balance between global ROI arguments and financial ROI arguments to leaderships of health systems changing in balance at all? And so I guess one example of this that I think of, I heard a physician sort of challenge the notion of working at top of license and really kind of propose that we think about it instead as working at top of purpose, really restoring time for physicians to be spending time on what they feel gives them the greatest sense of purpose and satisfaction from being a physician. How are intangibles like that really kind of captured in global or financial ROI, and how are kind of leadership teams at health systems or other organizations thinking about factoring that in?
I mean, I could take a stab, but I can tell you it's factored in. It's just that it's very difficult to, at the end of the day, I mean, look, the big, beautiful bill that just got passed is taking a hit on every health system across the United States. So there are financial pressures that have only been compounded in the last few months on health systems to be able to create a margin to be able to continue to function. And so my point is, in the world of increasing health pressure, financial pressures, CFOs are looking for every way they can, create an ROI from a financial perspective. Obviously, physician turnover is important, but the point is, if you're replacing that physician with another physician that's going to get burnt out, you're not really improving yourselves. So we have to take care of the providers of care. We have to take care of the physicians. It's unreasonable for them to go home and have to spend hours and hours and hours, pajama time, as Dr. Shah pointed out, having to do the work that should have been done during the normal working day, that they're having to now miss time with their families and so forth. So we have to be thinking about that if we're going to sustain ourselves. So all those things are factored in. But as I mentioned, the CFOs, all they look at is dollars each day, and they have to, because obviously we're under enormous pressures.
Yeah, the other way to look at this is, what if you don't invest in AI? Right now, we're at the point where AI is able to give us extremely reliable, not 100% accurate, but reliable um, clinical decision support tools in primary care. So, what if you miss a diagnosis or you miss a treatment plan on a patient because you didn't augment your work with AI, clinical decision support tool, which is so readily available, and not just to us, but also to the patient. So there is a liability, a legal aspect to us not embracing AI that I think needs to be taken into consideration when you look at return on investment. And a lot of it is also culture. You know, when all the hospitals and all the health systems start investing, it's kind of like a rolling ball. Everyone's going to, do it because you're going to have no choice to do it. Right now, we're at that early stage where some are scratching their heads. Should we do it? Should we not? But there will be a tipping point where there will be no choice but to go ahead and invest in AI technologies, because augmenting with AI is far superior to either one alone.
Again, I just to double down on everything that's been said, as I think about this concept of global ROI within the lens of this top of purpose consideration with AI in primary care is, again, not only reducing the cognitive load, but through that, you're freeing those clinicians to focus on those high value tasks, right? So the AI can handle the routine, repetitive admin work, but then those clinicians are able to spend time with more of the complex care decision, longitudinal care. And that way, it also enables the rest of the team. So you have more of a team based approach. Now you have nurses, pharmacists, care coordinators, MAs that, with the help of those AI support tools, can extend what they would have otherwise had to rely primarily on the physicians and advanced practitioners. So you're extending that reach. We talked about access. So increase the reach and access of providers without compromising the quality. And at the end, scaling high quality care, if you can also use those AI tools, as I mentioned previously, to ensure quality assurance checks in larger populations and larger volume clinics.
Yeah, I totally agree. Last week, Rock Health and the American Academy of Family Physicians published a report together that paints a vision for how AI can strengthen primary care and details specific ways that stakeholders across the ecosystem can take action. Dr. Jen Peña and Nipa Shah, you are both part of these efforts, and I'd love to hear from all of you, really. And I know there's no shortages of ideas in this virtual room. If there was one action or type of advance that you really see as the most critical at this point in time for advancing the role and impact of AI in primary care, I'd love to hear from each of you. What would that kind of one critical advance be?
For me, the one critical advance would be awareness and education. I go around the country speaking to so many audiences, and you'd be maybe you won't be surprised as to the lack of knowledge about not just the basic definitions of AI, but how it can be used. If there was one priority, it's awareness and education.
For me, the guardrails and the regulatory landscape that is so vague and undefined right now. So being able to, as we're developing these tools and implementing into our practice, start to develop those clear frameworks of responsible AI use, which I think is a work in progress.
If I were to tell you, today versus down the road, I mean, today I think the greatest pain point that I see is documentation. And if I were to say what's the one first thing I would try and do, it would be to enable some sort of documentation ambient listening tool, because that's something that physicians can feel today, and it's going to improve their life and improve their coding and improve all aspects of care. And I think that's a great entrance way for them to be able to get a taste of what AI can do for them. I think in the future, the greatest impact is going to be around decision support.
All great perspectives. And thank you all for sharing your insights on all the questions today. It's been great to have you on this virtual panel. Thanks again.